Thank you very much. Salam alaikum. Thank you for the invitation to be here. Sorry I can't be there in person, but this is modern life. So as you heard, I've been asked to talk about treatment of relapsed and refractory CLL. Here are my disclosures. The key learning objectives are how do we, in the modern era, select the correct treatment for our patients with relapsed and refractory CLL. So we have guidelines on how we treat patients now frontline, which of course is not the topic of my session, but of course how we treat patients at the time of relapse entirely depends upon how we treat them in the front line. And what you'll see is in the modern guidelines, there is very little room for conventional chemoimmunotherapy, although many of our patients in the past will have had chemoimmunotherapy and then relapse. But you'll see nowadays our decision is between continuous therapy with a BTK inhibitor or a fixed duration therapy with ibrutinib and venetoclax largely. For those patients that have TP53 mutations, of course, who used to have the very poor prognosis, those patients invariably treated now with novel agents. The evidence for suggesting we use novel agents rather than using chemoimmunotherapy comes now from multiple phase 3 trials, all of which have demonstrated the advantages of here BTK inhibitors versus chemotherapy in frontline therapy. The Illuminate trial looks at ibrutinib and obinutuzumab compared to chlorambucil obinutuzumab. The Alliance trial looks at either ibrutinib or ibrutinib plus rituximab versus bendamustine rituximab. The ECOG trial compared ibrutinib plus rituximab with what had been our standard of care for patients, that it was with FCR. And the Elevate trial compares chlorambucil obinutuzumab with either acalabrutinib alone or acalabrutinib plus obinutuzumab. And what you'll see in each of these studies is that there is a progression-free, and for several of these studies, notably the ECOG trial, and also an overall survival advantage for the use of these agents in frontline compared to chemoimmunotherapy. We, of course, have two approaches that we use in terms of using the novel agents. We can either use continuous therapy with BTK inhibitors, either ibrutinib or acalabrutinib, and increasingly now also we have access to zanubrutinib, or we used fixed duration therapy with venetoclax plus an anti-CD20, or with now ibrutinib plus venetoclax, for which we now also have licensing approval to use this combination. I think it's important to always try to assess the optimal use of these approaches and how we can select the right treatment for the right patient. And that's what I want to spend a little bit of time talking about with you today. Now, we know very well that in CLL, we have a balance between proliferation, which is driven through the B-cell receptor signaling pathway, and which are targeted by BTK inhibitors and by PI3 kinase inhibitors. And we have this process in CLL of very high levels of BCL2, which leads to resistance to apoptosis, which of course are inhibited by BCL2 inhibitors, notably venetoclax. The benefits of BTK inhibitor therapy come from continuous therapy. And without going into the detail with you in detail, we see worse outcomes in those patients who have therapy breaks or early discontinuations. Now, we know now from having used these BTK inhibitors for more than 10 years that they do have acceptable side effect profile, although there are some side effects that do occur. But importantly, we do not see any increase in the side effect profile over time. So therefore, when I've got a patient with a BTK inhibitor, my main issue is to try to support the patient throughout their treatment and not to interrupt or change the therapy prematurely. So our ESMO guidelines for the treatment of relapsed and refractory CLL are, of course, that in the majority of cases, we can continue to follow the patients until they become symptomatic. That is, when a patient relapses with CLL, it's not necessarily an indication for treatment. We would follow a watch and wait approach with the relapse disease in the same way we do with CLL in the front line. And again, we consider whether patients have TP53 mutations or not. And then the next thing we consider is how long was the duration of remission between their last therapy. And of course, the other factor we have to consider, as already mentioned, is what was the frontline therapy that they had. And again, you'll see in this setting, almost all of these boxes are filled with novel agents, and chemoimmunotherapy having a very limited, and I would argue now, no role to play in the management of relapsed refractory CLL. And I'll take you through that data now. So the selection of treatment for relapsed refractory CLL depends entirely on what was the treatment the patient received for in the past, what was the duration of response that they received, what are the side effect profile they had with the treatment, and what are the comorbidities that that patient has in terms of thinking about what other treatments they can have. We then have to consider the status of the disease. I'm talking now here about not only things like TP53 abnormalities, but also what I've mentioned before, which is watching and waiting these patients until they progress. Increasingly, it's important to consider the wish of the patient. In other words, what does the patient want to consider in terms of the various options we had available? Even, I have to say, in Saudi Arabia, you have to consider the financial considerations. These patients are going on potentially continuous long-term therapy with many of these agents, which have financial considerations. We have to consider what are the agents which are approved locally for your own local. And then, of course, the last thing to consider is what is your own experience of using and handling these agents in terms of managing that patient you have in front of you in terms of considering their treatment now. So let's look now at what is the data we have in the setting of relapsed refractory CLL. Now, here's the results from the RESONATE trial. This was the trial which led to the approval of ibrutinib in the setting of relapsed refractory CLL. And we've now got very long-term follow-up in this setting. And you'll see here that the progression-free survival of our patients with relapsed refractory CLL treated on the RESONATE trial is shown here, with now follow-up going out beyond 6 years. And you'll see this is vastly superior to the comparator arm. The thing we also have to remember when we look at the RESONATE trial is that the median lines of therapy that were on this trial were 3 or more lines of therapy for the vast majority of patients. We have good data that tells us that the earlier we treat a patient with ibrutinib, the better the outcome would be. So nowadays, if we're talking about first relapse and we're considering using ibrutinib, I would consider we would achieve very mumuch better outcomes that we're seeing here. The other feature which is very clear is that unlike chemotherapy, ibrutinib and acalabrutinib are able to overcome the poor prognostic feature associated with 17p deletions or TP53 mutations, which of course you'll be aware occur with increased frequency in the relapsed refractory setting than we see compared to frontline patients with CLL. This is the issue that I mentioned before. We've now got very long-term follow-up on the RESONATE trial, giving us good information on the side effect profile. And what's not shown very clearly here is this is the side effects which occur each year in each subsequent year. And you'll see that the side effect profile is generally low, but there's, with the exception of hypertension, which has to be looked for, none of these side effect profiles increase over time. There are issues like atrial fibrillation and hemorrhage, which have to be considered, but these are rarer side effects with these classes of drugs, but something that has to be remembered. But the important fact to remember is the side effect profile does not increase over time. Here's the data looking at acalabrutinib in the relapsed refractory setting. I showed you earlier on the results in the frontline setting. This is using acalabrutinib compared to either BR chemotherapy or idelalisib rituximab. This is one of the few clinical trials which has compared head-to-head acalabrutinib compared to a PI3 kinase inhibitor, which you'll see leads to an improvement with the BTK inhibitor. But also we see here the very significant improvement in outcome receiving acalabrutinib compared to bendamustine rituximab. Again, for me, a good reason to believe that in the relapse setting, we would not use chemotherapy, but instead use a novel agent. There are now a number of studies which have looked at the outcome of ibrutinib compared to, in the ELEVATE study, compared to acalabrutinib, showing that basically these two agents are very equivalent in their activity. some would argue that the side effect profile with acalabrutinib is slightly better. I would just say that the side effect profile is slightly different, but there are some side effects which appear to occur with a lower frequency with acalabrutinib, notably atrial fibrillation. Here's the data also on the head-to-head trial in the Alpine study of zanubrutinib compared to ibrutinib, demonstrating again that perhaps a slight improvement in outcome, but I'd point out the same thing happened with acalabrutinib earlier on, which then disappeared with longer follow-up, so that needs to be followed up. And again, the suggestion that zanubrutinib is at least equivalent to ibrutinib, but may be associated with a lower side effect profile. So what do we do, however, for those patients who have received ibrutinib or a BTK inhibitor as their frontline therapy? Well, then we're talking about moving on to using a venetoclax combination. And here in the relapse refractory setting, we have the Murano trial, which tells us what we can expect in this patient population. This was a multi-center phase 3 trial randomizing patients to receive either bendamustine rituximab or to receive venetoclax in combination with rituximab. Now, in this study, the venetoclax starts first as the ramp up, then the introduction of rituximab, and that rituximab continues for 6 cycles. Then there's a 2-year fixed duration therapy, 18 months of which after we complete the rituximab, and then the patients stop, and then we go on to observation. We've now got quite long-term follow-up demonstrating a very significant progression-free survival for venetoclax rituximab compared to what had previously been our standard of care with bendamustine rituximab, and that is sustained from that primary endpoint. So here is the time at which the patients stop the venetoclax, and you'll see that in this analysis, the 3-year, 4-year, and 5-year estimates show very significant improvement in progression-free survival of this therapy, even though the patients are off therapy at this point, compared to what we see with chemoimmunotherapy. Again, part of my argument is why I no longer offer chemoimmunotherapy, because we have clear data that both venetoclax rituximab as well as acalabrutinib is associated with improved outcome compared to chemoimmunotherapy. That progression-free survival benefit, I'm sorry, this slide is small and so busy, but the important thing is here, which is that there was no difference in any of the prior subgroups of the 2 groups here, demonstrating that in every subgroup that we look at, there is an improvement in outcome. I'm so sorry, I should have switched this phone off. This progression-free survival was maintained in patients who have TP53 mutations. We see that a slightly less good outcome for those patients with TP53 mutations using venetoclax rituximab compared to those that don't, but both arms very significantly improved over BR, and the same is true by the immunoglobulin mutational status. There is some data suggests now that those patients who have mutated immunoglobulin genes have better outcome in terms of the relapse refractory treatment compared to those who are unmutated. But again, both arms very significantly improved to that seen with chemoimmunotherapy. The important finding from the Murano trial, I think, in my mind, is an overall survival advantage. So for those people who thought that maybe I could give BR first and then follow it with venetoclax rituximab, the data against this is that we see an overall survival advantage in this that's maintained at that 2-year, 3-year, 4-year, and perhaps even wider at the 5-year estimate in terms of how we look at this patient population. And of course, when we do a randomized trial and we see an overall survival advantage, in my mind, this is the clearest evidence why we should be using a novel agent rather than chemoimmunotherapy in this setting. Now, the landmark analysis and of course, how we're able to stop therapy is that we see that those patients who are MRD negative at the end of treatment have a very much better outcome than those who are MRD positive. And that's true in terms of progression-free survival and now also in true of overall survival. So whereas it's true to say that the patients who are MRD negative do better, where does that leave us in terms of what we do in those patients who are MRD positive? Well, I have to say that given that even some of the MRD positive patients can have quite a long progression-free survival, I continue to observe these patients off therapy and look to offer them salvage therapy at the time of progression of disease, again, when they need next line therapy later. The side effect profile associated with the venetoclax rituximab was very favorable. There is a signal of neutropenia, but the neutropenia associated with venetoclax rituximab very different from the neutropenia that we see in patient populations receiving bendamustine rituximab, very sensitive and very responsive to the use of growth factors and not associated with any increased risk of febrile neutropenia. Now, what about other approaches we can have? Well, I already mentioned we now have licensing approval for ibrutinib used in combination with ibrutinib. I'm showing you here the results of the Clarity trial, which is a trial that we did in the UK, looking at using this combination. Now, this particular academic trial uses MRD endpoints as the study end, but the design of the study is not too dissimilar from how we're using this by its license. That is, we start the patients on ibrutinib, which they receive for 2 months. Then we add in the venetoclax and continue that therapy. And in the GLOW study and in the licensing approval, at the end of that 1 year of fixed therapy, we stop. In this academic trial, we continued to monitor their MRD levels, and we continued the treatment based upon whether they were MRD positive or negative. And in this trial, we can see that by following the MRD, we see that those patients who have a rapid response and become MRD negative quickly are those patients who have the very best outcome. But even those patients who are MRD positive tend not to become MRD negative, but we can continue to see the levels of the disease continue to drop for a longer period of time also. The outcome we see in these sorts of combination trials appear really excellent for a relapsed refractory patient population. You'll see here the progression-free and overall survival. Now, clearly, this is only with 3-year follow-up, and longer follow-up is required, but these are really outstanding results to see in our groups of patients. What do we think about from what's there for the near future for our patients with CLL? Well, one is the use of pirtobrutinib, the LOXO 305 from the Bruin study. This is a novel PI3 kinase inhibitor, a BTK inhibitor, which works in a very different way from ibrutinib, acalabrutinib, and zanubrutinib. And what you'll see here is that we see very high response rates, even in those patients who have been refractory to a previous BTK inhibitor, and even in those patients who progressed on BTK inhibitors. So what we do see here is that we know that pirtobrutinib is able to overcome the defects, the inability of these patients to respond anymore to standard BTK inhibitors. We know that we have durable disease responses, and perhaps that's due to more of the B cells. We're looking at how ibrutinib can modulate immune responses. We see also that ibrutinib does have effects through ITK that, and can restore T cell function. So a feature that ibrutinib seems to be able to have is to restore that function, which of course leads us on to where I think we're going next in terms of relapsed refractory CLL, which is CAR T cells. And we see in the lisocabtagene maraleucel studies, which I think is going to be the first product licensed and approved in CLL, that we do see very refractory patients able to respond. And we see that when we add in ibrutinib into being able to collect the CAR T cells, we look as if we're able to see even better outcomes. So in summary, at the very last slide, I promise you, novel agents have replaced chemoimmunotherapy in the treatment. We have choices, continuous therapies, fixed duration antibodies, or fixed duration combinations. Ibrutinib modulates the impaired response. There are novel agents on the horizon. So if you have a patient who received a BTK inhibitor frontline, we move them to venetoclax. If you've got a patient who received frontline with venetoclax, we move them to ibrutinib. If they've had chemoimmunotherapy, you have choices. With that, I'd like to thank you very much for your attention, and sorry if I overran my time. Thank you.